You said as an idea essentially for a Walmart parking lot, or something that's more a community-based effort of reaching out to the patients. And my first thought is, of course, when you look at community-based diabetes efforts, if we would focus solely on diabetes, it's really focused on hotspots, regional areas where maybe the literacy.
Sure.
Health literacy is low, but disease prevalence is high, and screening measures
Sure.
need to be more greatly improved. I can't help but imagine that this could be regionally addressed.
Yeah. No, there's a lot of data looking at the barriers to screening, telemedicine screening, and a lot of it has to, as you say, to do with the educational understanding. Trust is an issue. Socioeconomic conditions, as you can imagine, are issues. So it's a matter of finding how to balance all those barriers, and then the risk, when you have higher populations of diabetics, you have people who've lost vision in one eye. Fear of losing vision in the other eye is a very good enabler to start, using screening technology, and to work probably, honestly, I think we could do a better job of working with primary care doctors, because those are where those patients are presenting between the two of us. They typically show up with us much later stages. So I think we've made that move in that direction with all the requirements of communications and so forth. I think we can do a better job. It's a matter of finding how to make it work and having enough time in the day to pull it all together.
Yeah. I always feel that primary care, particularly because of the dynamic of trust established between a patient who would be at greater risk of this, and referring into the next stage is always just a prime opportunity to get them and keep them informed.
And again, diabetic retinopathy is preventable. I mean, that's what we need to get to. We need to get to the primary care doctors, because those are one who have the ability for prevention and probably educational standpoint from their perspective, and perhaps in our perspective, to understand the difficulty of managing these patients. We understand diabetes is a difficult disease to control because you never feel sick until very late stages. And I think that's almost unfortunate. You don't take it seriously until you've had pretty detrimental effects from it.
Yeah, absolutely. 100%. Well, your team's findings, certainly, it was a great answer, but of course it presented so many other questions, which is usually great, right? For research, that's exactly what you do, find the next question. So if we're looking at this tangibly for very next steps, what do they look like, Dr. Lawani?
So unfortunately, I think we're limited on the amount of information that these patients had in this screening problem. We could go back further and analyze photography for, as I said, the physical characteristics of what could we identify early to say patients would go on to develop more severe forms of diabetic retinopathy. That would be nice with this study, to do perhaps more research, like I said, into the genetics and looking for different biomarkers and signaling pathways. There are, as you know, other pharmaceutical developments in process already trying to target those pathways, and so perhaps we're more ahead of the game than we think we are.
And certainly the way you've presented it is that, this is a specialty that's on the precipice of making that jump to innovation and, advancement of technology, greater embrace of more recent innovations with proven practices. So with that in mind, Dr. Lawani, is there anything you'd want to add regarding, of course, us coordinating virtually right now as opposed to on the conference hall floor, and us moving to this space right now? I know ophthalmology really prides itself, it seems, on a very collaborative, close-knit network. How are you guys staying connected, especially for meetings like this?
Zoom. Lots of great meetings out there that have tried to put an innovative spin on it. I think Zoom technology is fantastic for allowing this. It allows multiple people to get in together. I wish I had bought stock in the company back in March. But so I think that we're trying to connect. We're trying to maintain these things in larger meetings. As you know, like ASRS is phenomenal for what they're about to pull off here at a meeting of this size, but also breaking it down into smaller meetings and staying connected and doing the best you can. We're all looking forward to being in person. We all prefer that. We all prefer seeing each other. And it's unfortunate because that's where a lot of collaboration comes from, is not just in the meeting hall, but it's when you walk out, to lunch or whatever to grab a drink, you're like, hey, this, and that part of this is unfortunately, I think, missing. We'll find ways. It'll work.
Yeah. Can't replace that factor of running into someone and, catching
Yeah,
them in the moment. But,
absolutely.
nonetheless, I think you're right. It's a great alternative. So,
Yeah.
all right, Dr. Alawani, anything else you want to add relevant to your team's study, any further research or any other topics?
No, I think, like I said, I think artificial intelligence is what's going to help us solve this diabetic retinopathy problem because we know how to prevent it. It's just identifying patients. So, and this proved more than ever how important it is to identify those patients early on.
Yeah. Yeah. It's a hugely, and it's just going to get even more important topic in the field. So thank you so much for your time and
Thank
perspective
you for
and
having me.
expertise on this.